Well, good afternoon, everyone. We will get started in just a minute with today's edition of Arizona Community Grand Rounds. And we'll just let folks join and then we will begin. Well, thank you for connecting and joining us today on the September edition of Arizona Community Grand Rounds. My name is Mark Carroll. I'm the Chief Medical Officer with Health Choice Arizona. And these rounds are co-hosted by the NARB Institute. And thanks to Mary Jo Gregory, the President and CEO of the NARB Institute, along with Health Choice Arizona, we're pleased to offer just conversational settings for us to collaboratively and collectively learn about key topics and critical topics for our time. And today we actually have a fantastic panel of folks who have agreed to be part of a conversation on pediatrics and the pandemic. If this is your first time to these rounds, your mics are muted, but you're able to ask questions through the chat and the Q&A. And we invite you to do that throughout the course of the session today. Mary Jo and I will do our best to keep up with the questions and comments and then intersperse them appropriately during the course of today's session. In addition, all the rounds are recorded and they're available on the NARB Institute website. And once we get a couple minutes into the session, Jen Pierce, who makes all the magic happen behind the scenes and keeps us technically afloat and technically moving forward. Thank you, Jen. But Jen will put in a link for how to see this and recordings of other sessions at your leisure. So we will jump right in because we have a great group of folks and really important topics to consider today. My introductions will be very brief and I'll move them north to south in the state from our expert group of pediatric leaders. And then we'll hear some perspective from those leaders moving roughly from south back to north. So joining us, actually not sitting currently in her role as the Chief of Pediatrics of the Tuba City Regional Healthcare Corporation is Dr. Sara Jager. And Sara is out of the office today, but she's so committed to our work that on her personal time off, she's joining us. So thanks, Sara. Sheila Mackell is a partner and longtime community pediatrician at Mountain View Pediatrics in Flagstaff. And has also been a consultant with Coconino County. So thanks, Sheila, for joining. Mike Ritchey is the Chief Medical Officer for the Phoenix Children's Hospital in Phoenix. And Sean Elliott is in Tucson. And Sean is Sean, you have a few titles, so I'm going to go and get these right here. Emeritus Professor of Pediatrics at the U of A College of Medicine, an ID physician at Tucson Medical Center, and the medical director of ID and Immunizations for the Arizona chapter of the AAP. Hopefully I did justice to all of your backgrounds. My apologies that I went so briefly over them because you all are pretty impressive folks with amazing bios. So we're going to jump right in. And Sean, I wonder if we can begin with you, if you wouldn't mind commenting from your perspective on some trends that you're seeing, any key themes that you'd like to share with folks related to peds and the pandemic?
Great. Thank you, Mark. And hello, everyone. Good afternoon. It's great to be here. I think we all know that the country is still in the middle of a current surge with the Delta variant of SARS coronavirus 2. Although there are some indications that parts of the country and some of the earliest states are now starting to plateau. But pertinent to this conversation, we are finally, unfortunately, seeing a much bigger impact on pediatrics from coronavirus and other respiratory viruses than we have so far yet in the pandemic. A couple reasons for that: it appears the Delta variant is as with every variant, more contagious than the one before, 50 to 60% more contagious than the Alpha variant, which was the B.1.1.7 initially from the United Kingdom. And there are indications that it is also causing greater disease spread and perhaps even greater virulence. The truth of the matter is it's no longer just adults who are the contagious ones, but it's our kids. And the initial truisms of kids under age 10 not being contagious in the school setting or the home setting, et cetera, are no longer holding true. In fact, there are some studies already that pediatrics from birth through 19 are becoming just as contagious with SARS coronavirus 2 as we typically expect every year with influenza. That's unfortunate because it means that the traditional metric or rubric, I should say, of kids acquiring disease at school, bringing it home to the parents and the caretakers who then take it to their places of work is now showing itself to be quite true for COVID-19. As well, we're seeing more frequent hospitalizations of kids, and this is also new to the pandemic. So far, thankfully, most kids with COVID-19 had mild or even asymptomatic disease, and if they were hospitalized, it was typically complications of a comorbidity. Now we are seeing kids, some with comorbidities such as obesity, diabetes, immunodepression, you name it, and others who are otherwise healthy, immunologically and otherwise, but we're seeing kids being admitted with primary respiratory failure, requiring oxygen and dexamethasone steroids and remdesivir and all the other things that we do. And that is unfortunately driving a burdening of pediatric healthcare centers, both inpatient as well as urgent care emergency departments, and then freestanding and hospital within hospital children's hospitals. There are certainly some of the earlier states in the most recent pandemic surge, the Delta surge, children's hospitals that are overwhelmed and starting to have to ration healthcare. So ventilators, ECMO circuits, I mean, this is just as bad as it was in 2009 with the influenza A H1N1. So that's the reality on the ground. Locally speaking, I know I look forward to hearing from the others on the panel about their local experiences, but things are starting to plateau here in Tucson at least. But we have patients in-house right now with COVID and other things. Along with that, I think no one will be surprised that as with the rest of the country, we're seeing other respiratory viruses. So in fact, I was just communicating with the medical director of the Pima County Health Department, confirming that yes, indeed, 50% of our hospitalized census at my hospital is RSV bronchiolitis. It ain't supposed to happen right now. We know that. Pediatricians know this is a winter disease, but we're seeing the winter time in late summer. And it's not just RSV. This has been a nasty season, a nasty month for rhinovirus/enterovirus, and it's affecting not just kids, but adults, which means, of course, that there's plenty of interplay in the home setting and parents infecting children and vice versa. We are also seeing our first sporadic influenza cases. Yes, it's starting. And then other things like adenovirus, parainfluenza. We have patients coming with croup and COVID. So it's busy. It's busy. And I imagine most healthcare providers who deal with pediatrics are seeing, if not near complete capacity, but close to it. That's kind of the active and acute disease. The other trend which we're seeing, Mark, is now an increase in our pediatric patients with MIS-C, or multisystem inflammatory syndrome in children. And not too surprisingly, we're 3 or 4 weeks into local surges. Now's the time to see a post-infectious autoimmune or potentially hyperimmune vasculitis, which is the MIS-C. And we're seeing it in increasingly younger patient populations. I just had the unfortunate privilege of treating the youngest patient, a 4-month-old, who initially was infected and developed symptoms in Mexico, and fortunately made it across the border to seek care. And one of the highest, meaning worst degrees of cardiac involvement that I've seen so far in the pandemic. The other challenge is that these patients with the MIS-C are presenting in local environments and rural environments with a gastrointestinal presentation. So Fevers, without necessarily a known COVID disease or COVID exposure, but fevers and then vomiting, nausea, vomiting, anorexia. Some are presenting as an apparent early appendicitis, and that's the pathway they go down in evaluation. And there have already been several patients who presented to a local emergency department, appropriately evaluated as a viral acute gastroenteritis and discharged home, and then returned hopefully later much sicker. There in fact was one 22-month-old who was discharged home from a local ED and then was found dead in bed at home the next day. So this is scary. It scares me because the kids coming in have very non-specific presentations, and hopefully the attendees on this session can take away the awareness and the need to further evaluate kids potentially with a COVID exposure and or who come in with fevers and new onset GI symptoms. Consider doing the inflammatory marker labs just to try and pick up those kids who have a SED rate over 40 and potentially evidence of cardiac involvement. So that's kind of where things are standing. No new real developments in terms of treatment, either for adults or for kids. Certainly, there are still the criteria to use dexamethasone, so steroid challenge, and patients coming in with mild to moderate disease and an oxygen requirement. The use of remdesivir, still reasonable for kids in that same picture. But there are some patients who come in a little bit even too sick to start the remdesivir, meaning they may come into hospital already requiring high flow nasocannula oxygen, bordering on intubation ventilation. Those are patients in whom remdesivir has not been shown to affect the outcome. So we want the kids coming in on just nasal cannula or maybe face mask oxygen with COVID-19 who would benefit from steroids and remdesivir. We'd all like to be using the monoclonal antibodies, the biologics, but there's of course a international shortage. So tocilizumab would be ideal if we could get it, but we so far have not been able to. The overall remaining, I guess, point to make is that in general, kids still have good outcomes, even if they're hospitalized. They're in hospital longer than anybody would like, of course, but they're going home, which is great. And knock on wood, not as many fatalities as one could anticipate. That being said, Arizona is still number 2 in the country in terms of pediatric deaths related to COVID-19. Second only to Texas. Texas obviously has a larger pediatric population. So per 100,000 kids, Arizona is number 1, and it's not a good thing to be number 1 at. So that's kind of the epidemiologic and clinical updates on my part. I'll turn it over to others to share what they're seeing in the front lines, what they're seeing in terms of related challenges as well. So thank you.
Thank you very much for that great brief summary. 2 quick questions, if I may, before we return to Dr. Ritchey. The first, in the Q&A, can you speak to ivermectin? A lot of conversation about ivermectin out there. I'm not surprised it wasn't the first question today.
Yeah. Oh, yeah. I wish. I wish we could have a definitive resounding ivermectin does not work and it carries side effects you don't want. Knowledge base, but that is not true. So continued requests for prescriptions, especially to my adult infectious disease provider colleagues. There is no evidence that ivermectin has any theoretic or any therapeutic benefit in SARS coronavirus 2. People ask, well, how did it get on the map in the first place? And just like hydroxychloroquine, the pharmacokinetics, the physiology of how both of those drugs work suggest that they could have an impact on a virus like SARS coronavirus 2. But the reality based on population studies and now meta-analyses just being published is that neither of those drugs has any benefit whatsoever, and both have a significant risk profile when used at all, and certainly when used inappropriately.
Yeah, thank you. I was just going to ask very briefly about other monoclonals. You mentioned the shortage of monoclonals that have been antibodies, monoclonal antibodies that have been used in inpatient for some time, but there are the newer antibodies that are used in a more preventive or early treatment in the ambulatory space. Are you using them for kids and recommending their use, at least for teenagers?
Yes, absolutely. The 2 combination monoclonal antibody cocktails with 2 providers retain activity against Delta variant and all the other variants so far. And indeed, they are indicated they do have clinical impact and have shown themselves to be quite successful at intervening in early, mild to even moderate COVID-19 to limit or reduce the risk of hospitalization. There are criteria for their use established by CDC and the FDA, and those are age 12 and up with the weight cutoff as well, and then presence of at least one comorbidity. So that would be an increased BMI, certainly a BMI of 40 and higher would qualify, but so too would be 30 and up. Presence of pre-existing cardiopulmonary disease, long-standing, presence of prematurity, immunodeficiency, and this is perhaps the most permissive criteria of all for kids, is presence of a respiratory illness on a daily control or medication. Think of all our asthmatics who are on a daily control or MDI or inhaler. They would qualify for use of either of the monoclonal antibody cocktails were they to get COVID-19. So absolutely support their use. There's been underutilization of those products, and there's plenty right now from what I understand. So the challenge is to get monoclonal antibodies into people who deserve them to try and limit hospitalizations.
Yeah, thank you so much.
Great, thanks.
Dr. Ritchey, how about some perspective from you from Phoenix Children's and your role there?
Sure. It's been quite a year and a half dealing with COVID for all of us, but I guess I just would talk about more recent events. And as Sean has pointed out, we definitely are seeing a surge in pediatric cases. I mean, probably reflects a number of things: the lack of vaccination for the kids, but also now all the little vectors running around the school and everybody getting infected definitely has a role. It's impacted us in terms of census, but Sean did say, I think what's impacted us the most are the other respiratory viruses. It does create some issues for us, particularly as people come through the ED trying to get the testing done, figure out what they have, and it sort of delays the throughput. I can say that our ED has just been overwhelmed. We recorded our highest numbers ever at Phoenix Children's. We sometimes see over 400 patients a day in the emergency room, which is just astounding. But it does impact, the throughput in the ED, and people often don't stay and receive their care because there's too many people waiting. We've had a big problem with kids being brought in for just testing, and that seemed to slow down this week. But the schools, want everyone to go get tested. If they have 2 kids that are positive, that's an outbreak for the school, and they don't tell them where the resources are to go get tested. So we tried to defer or delay people from coming here and even offering home testing kits to them if they choose that option. But our census has been overwhelming. We have had our highest census for the summertime ever, and as all health systems are seeing, we're struggling with staffing. A lot of people, nurses, have left the profession, and you can't get a traveling nurse because in previous surges it was varying amounts in different parts of the country, and we were able to get traveling nurses to come in when New York had died down or whatever, but every state's affected right now, so you just can't get those people in. So it's really become a stressor for our staff. I mean, I think burnout's a real concern. As I know, Mark, you really think about this a lot, but I think now we're seeing it as much as any other time. The one comment I'll make about our COVID admissions now, even though the number of cases in Arizona is not as high as it was with our December surge, our number of pediatric admissions is just as high. And we are seeing a fairly high number of ICU level care. A lot of them still have comorbidities, but not all do. What's really, disappointing is the number of kids we see with chronic health conditions, like kids getting admitted, cardiac problems, have had cardiac surgery. They're coming in, they're sick, they're in the CVICU, and none of the family's been vaccinated. I mean, they got it actually from their parents, and these are preschool age kids. And that's been the theme throughout this last surge. I mean, virtually every admission, no one in the family is vaccinated. We've had one partially vaccinated teenager admitted who was ill, and all the others, it's, the whole family's just had coronavirus and no one's been vaccinated. And a lot of these admissions could have been prevented, and, some serious illnesses could have been avoided. And I don't know, it's just disheartening that, we can't move the needle enough on the vaccination to prevent this. And I think it's going to be a problem for us for a while yet to come.
Those are really important points. Thanks for sharing those. And This summer is not as odd as both you and Sean have mentioned, not because of the surge and the unfortunate impact it's having on kids now of COVID, but also of other conditions. Mike, with your specialist group or really any of the panelists, any thoughts about why the epidemiology of other viral infections that used to follow their season, right? They were supposed to stay in their season. Why they're outside of their season and what this means for us moving forward. Any perspective from science or even some good epi insights?
Yeah, I have my thoughts, but I'll defer to the expert on the panel.
Well, I have thoughts too, but I'm not sure anybody has a whole bunch of evidence about exactly where RSV hides in the off season. And for example, that same thing with influenza. Certainly, everyone points to the fact that as a society, we came out from behind the masks and we removed our social distancing. And so kids who were harboring, plenty of microbes and viruses at the best of times had the ability to share and spread and disseminate. It's just interesting to note that that same pattern does not hold true in other times of the year prior to the pandemic. And it just begs the question, like, where exactly is the RSV reservoir in the off season? I wish I had a good explanation for that. People pointed to local factors of respiratory epithelium, so temperature, humidity, but all of those currently would normally favor not an RSV season. So I just have to say there's probably a built-up volume of RSV out there, and we took off the masks, and we're seeing a surge of kids who are just sharing and then coming into hospital.
Sean, this is, oh, go ahead.
Oh, no, I interrupted. Was that you, Sarah? Go ahead.
Yeah,
please.
it's me. Sean, I was wondering about, and this is that clairvoyance that we were talking about in our pre-meeting, but what do you think will happen with the flu, since we didn't have flu last year either? Are we down? Is it going to be worse, do you think, because we don't have built up immunity from last year's flu season, or we don't know?
Yeah, absolutely. The answer is an unequivocal yes, maybe. I think everyone is worried that same thing is happening with RSV will happen with influenza, that we have dropped immunity. People are now a year and a half out from their last exposure. And immunity against the flu lasts a good 6 to 8 months, either from vaccine or from infection. So we have a whole bunch of people worldwide who are flu at risk. And it's really unclear what the flu viruses have been doing in terms of mutations in the last year and a half. There's not been a viral load, but yet there's still antigenic drifting and shifting as a possibility. So every concern is that it's going to be a nasty flu season, but we have no indications to go by because the Southern Hemisphere, where we track our numbers, for example, Australia, New Zealand, have not had a flu season again. So we don't really have much data to go on. My personal concern is, yeah, it's coming. We're seeing sporadic cases already. I'll be stepping up to get my flu vaccine as soon as it's ready.
Yeah, I had my flu vaccine last Friday. I took the opportunity to also have the shingles vaccine along with it because I'm of the age, I've been of the age for a while and I haven't done it. I will just share with everyone that I didn't feel at my best over the weekend, but I'm glad I did it. I do wonder, and I'm curious if anyone has perspective on this in your careers, but how you feel we're going to learn more about our immune systems. There was a question about our immune systems that's come in because of COVID. Do you think we're going to actually learn and we can get COVID in some stable place, hopefully behind us, or at least in a stable place moving forward? Do you think that we're going to have insights into our immune systems that will be helpful for us and our kids in particular moving forward, regardless of what the infection may be that's circulating in communities? Any perspective on that?
I hate to monopolize the conversation. I have a couple thoughts about that as well. And it's largely due to our experiences with mRNA vaccines, which, in case anybody's still under this misillusion, this is not new science, not new technology. The concept of RNA and DNA vaccines has been around since I was in fellowship just 25 years ago. But in terms of vaccine products and their impact on the immune system, the experience has been now for the last decade plus. I think we're starting to understand the importance of neutralizing antibodies versus binding or opsonizing antibodies. Not that this is new immunologic understanding, but I think it's more common knowledge that the immune system is complex, and how we can best manipulate it through vaccines and also monoclonal antibodies for patient safety. So that's a circuitous way of saying that I'm not sure our scientific understanding of immunology has increased significantly, but our application of it certainly has. And if that's a silver lining from the vaccine, from the pandemic, then we'll go for it.
Yeah, thanks. I think we have to find those opportunities, right, that are, as the expression is, silver linings, where we can learn about some conditions that perhaps we haven't understood as well in the past, and maybe MISC, long COVID, and other types of activities provide an opportunity for us, and we're really fortunate to have folks on some of your staffs and you all who are able to help us think our way through that moving forward. Sheila, primary care is really busy these days, is it not? You shared with me some perspective last week. How are things going from you and from your perspective and your colleagues, and what would you like to share with our participants today?
Well, thanks everyone, and I'll echo all of the things that have been said already about the tremendous increase in illness burden. We saw nothing last year, basically, until this past summer. And from the number of patient calls in our 9-provider office is nearing 200 on some days, which is amazing, triple the normal. And it's largely indistinguishable calls because they're all, many of them, just standard respiratory illnesses. Since school has returned, looking for testing, especially we've had a great availability of testing for kids in our county. We've flexibly made a testing site at our office for kids under 5 that can come and get rapid tests, because that has been a big vacuum. But the level of uncertainty and the parental worry from the newborn nursery up, it has just exponentially happened this summer. I want to say, we all are dealing with vaccine hesitancy, but we're also dealing with a lot of vaccine enthusiasm. So many kids are so proud to show us their vaccine card that they've been vaccinated. And we've been trying to use every opportunity at every level for every visit to talk about how the best protection for kids who can't be vaccinated is to vaccinate the family. And so lots of challenges on the patient diagnostics, especially in terms of sort of sorting the pile of who actually needs to be seen for the precious few appointments we often have. We've had the unique monsoon season up here in northern Arizona too, which has brought some unexpected local transmission of Salmonella, E. coli O157, Sapovirus, Norovirus, and Rotavirus, kind of unexpectedly in little complexes that we've been trying to make sure they weren't MISC, but they have turned out to be quite an interesting infectious summer. One of the other things that we found on the primary care level, at every level through all parts of the pandemic, is the really lack of the severe need for more behavioral health services. The number of kids who have been in distress all through their online education and through a summer, and now even in distress as they're back at school, has been rather dramatic, and the wait lists are quite long. So many of the appointments we have, people just want to not only fill out surveys, but really just try to find a place where they can get some help. From our practice standpoint, we've had some interesting things over the last year, and more severely now, I think, because we haven't been able to really see the number of patients we were previously able to, just between the complexities of checking people in the car and getting them into the office, people in PPE, our separation of sick and well visits. It's hard to meet the goals that are set out by different companies for for reimbursement. And then we're all dealing with the same thing with staffing shortages. You know, if some of our staff's children are now in quarantine, they're out for a certain number of days, and that again makes everybody doing quadruple duty. So we've been trying to be nimble. We learned quickly 3 telehealth platforms within about a week last year, and we're trying to sort of sort that through and be able to provide some medical home service as well as non-urgent behavioral health, asthma, ADHD type of services, and sort of still trying to maintain advocacy for kids in the community at the school level and at our community level. And lastly, I just want to say, I think all of us are feeling a severe need to support our staff. You know, the providers on many levels are having a lot of despair about the way things have moved through this summer. And we're looking into the winter with all of the emergence of RSV and the things we are seeing in our office now, and trying to figure out ways that we can also provide support for our staff so they'll still want to be here, because we do tend to have a very cohesive team.
Thank you.
So that's where it is down here on the ground. Mm-hmm.
Well, I was struck by, Sean, you mentioned numbers, inpatient, Mike, same, and Sheila, and I'm sure we'll hear from Sarah, it's the same at the outpatient level. But you mentioned to me last week, Sheila, that this is busier than you see on any typical winter day when there's a lot of other viruses like RSV and flu circulating, which puts just extra strain on everyone. And I don't think we can underemphasize that. I know that you all have mentioned it, just the tremendous strain on every Arizonan, and the strain on families and the strain on those who are caring for families. Any pearls or insights, Sheila, that you would share about just what you and your team have found to get through each day or to make improvements week to week?
Well, we've had a lot of in-office opportunities. We have a lot more meetings, a lot more communication with the staff, and each of the front office, our back office, and all of the physicians. Since so many of the protocols are changing, the availability of various testing, we have in-office testing that is on certain days functional, on certain days less so, and just the absolute increase and need for all of us to communicate what's actually happened on a given day, because not everybody's here on the same day. And that has, I think that has helped. And the transparency that we're trying to maintain with all of our staff and all of our phone staff. We've been really fortunate.
I think that transparency.
I'm sorry, we've been really fortunate to be able to do a lot of our communication. Pediatric parents are young and their social media use is tremendous. And so we've communicated a lot through the social media platforms and to keep the patients informed of how things are changing.
Thank you. Sorry to interrupt you. I just think that transparency and that authenticity that so many of you have shared just with me, both the panelists and I think probably a lot of attendees today, is I know that those small supports are very meaningful in large ways moving forward. Mike, did you have any perspective on that?
I just was going to make a comment, maybe a question for Sheila. Our urgent care providers, as well as some of the ED staff, feel like a lot of the people presenting the ED, not just for testing, but that are coming with symptoms, normally would never have presented. In years past, they would have gone to school with their flu symptoms. And I think that's what's really leading to the volumes in our clinics, that people are coming in just because they want to be sure they don't have COVID, where in the past okay, I got the flu, it's okay, I'll recover from that.
Absolutely. People want to know yes or no. And if they're symptomatic, the rapid tests in the office are relatively reliable if they're positive, not necessarily if they're negative. And going through all of those decision trees, the school has been welcoming in sharing all of their protocols. So we've been able to work through the algorithms with parents, but they just look like some kids, they just look like they have a cold. And that's the tricky part of all of this, is sorting out who gets what. And we are really fortunate, as I said, because our county has supplied us with a lot of testing, and we have saliva testing for anyone over age 5 that's for free and relatively easy to access. So it's just the testing of the younger and the immediacy of people wanting to know.
Yeah, thank you. Thank you for that update and response. I just was going to share, looking at the chat, Dr. Leonard from the Indian Health Service in the Phoenix area shared that their behavioral health team holds a weekly support call for clinicians, tribal and Indian Health Service behavioral health providers. And a lot of people call in for half an hour a week. And at least you noted here, it's so little, but so appreciated. I actually want to turn to Dr. Jager about it's so little, because I was so impressed by some of the things that Sara, you and your colleagues in Tuba City have done when you share with others, that you said, well, they were just little things that you weren't sure had big impact, but they did have big impact. And a lot of people listening when you shared that some months ago really thought so. So that, at least thank you for the comment. For other questions that have come in the chat, we're going to come back to those in a second. But Sara, do you want to talk a little bit about the experience in Tuba City? You were the CMO during the hardest times of some of this in the past year, and now as chief of peds I've seen a lot because of the experience that occurred on Western Navajo in Tuba City.
For sure. Thanks, Mark. Can you hear me okay?
Yes.
Okay, perfect. So I'm Sara Jager, no longer Steve Holvey. After 33 years, Steve Holvey has given up the lead at Tuba City to me. And I was the chief medical officer, the interim, for the first year of the pandemic. And our pediatricians had to be repurposed for a lot of different things. So Diana Hu and Amanda Burridge, very excellent primary care pediatricians, are also still running the epi response in Tuba City. But I got to back away from hospital leadership and come into this job, so I'm grateful for that. The reason that I love participating in these things, like being able to share some information that I have for you all, but I also need 3 things from you. So 3 things to think about before I go into what we are doing in Tuba. What capabilities are you all using for school outreach to deliver care at schools? I think that's a burgeoning field that we have not tapped into at Tuba. We have high school clinics, and so one of our high schools is back to in-person full-time. All of the Tuba City schools and all of Navajo Nation were out of school until this fall. And we'll get to some of the challenges about what that's meant in a rural place that doesn't have internet. And so what are we doing at school to reach some of these kids without going through mental health as an intermediary, or even for being able to deliver care at the time that they're sick at school? We do send pediatricians out to our Warrior High School, but that's only one of the 5 schools in Tuba. So I'm interested to see how people are developing those capabilities. Is anyone doing obesity intervention that's working? Because we are failing. And this Zoom school life that our kids did, they just would like swing through the kitchen and pick up some snacks in between each of their classes. And I'm not talking 5 or 10 pounds. We had an obesity problem in Tuba City beforehand. 33% of our 9 to 12-year-olds are overweight, and of those, 30% of those, 50% are morbidly obese. So it's a significant problem. But we're just 50 to 60 pounds in the last 18 months on these kids' tiny frames, and so what we're doing isn't working. And I'm interested to hear what other programs people are pursuing. And then public health messaging. So Sheila was commenting that she was using social media. We use Facebook a little bit, but probably not enough. But what public health messaging is working to get people vaccinated? So we had a high acceptance rate. The vaccine came to Tuba City when we were in the throes of our winter surge. And so everyone was getting vaccinated. I think more than 70% of our elders are vaccinated, but only still about 50% of our kids over 12 are vaccinated. So I'm interested to hear what people are doing for community outreach, for public health messaging, to try to get kids in. And I'm looking for ways to increase our vaccination rates. So Tuba, for those of you that don't know, is about 80 miles north of Flagstaff, and it's on the western res. We have a catchment area of about 20 to 30,000 people. We see about 15,000 visits a year in outpatient peds pre-pandemic, and we do have an inpatient unit, but we had to close that down so that we could change those to adult beds, and our peds nurses were sent to work on the adult wards in the respiratory care unit. And we just reopened our peds ward in May of this year. And I gotta say, we have, for the high disease burden that we have had throughout this entire pandemic from March 6th, which was our epicenter, like day one, we have not had many admissions. We've sent, I think, 2 kids to PCH for a rule out of MIS-C, and they both ended up having Kawasaki disease or staph scalded skin. And so no true MIS-C, which is really incredible because we have had such high disease burden in Tuba that the kids were automatically getting sick in these multi-generational homes. So I think that will be a very interesting study. Eventually somebody will come up with why that happened. We are doing Regeneron here, 12 and up. And we haven't had many kids that have opted for that, but our adult patients are doing it more and more, and we're doing it through the weekend as well. So we've been able to set up that, and it's pretty slick process. The contact tracers, from the positive results called to the contact tracer to getting them scheduled on the schedule, like it's really one of the things that's going well in Tuba, and it's been awesome. As I mentioned, our skyrocketing obesity is a real problem. And we don't have good obesity intervention programs, and many of our community is still very frightened. And so we did a bunch of sports physicals. Irony of all ironies, we were really busy for 6 weeks for all those sports physicals, but now some of the schools have rolled back and said we're not going to play sports, or there's an outbreak on the football team, and then everything is shut down for another 2 weeks. We don't see any sick visits in our clinic, so all of those go to our triage tent, which is open from 8 to 4:30 every day, or the ER. And it's probably an increased ER burden of about 13 kids a day for their respiratory stuff. But if you just want a test and a note for school, you can get that outside, and you never have to access ER services or pediatric services, although the pediatricians and the CMAs from Peds Clinic are staffing that tent, but just not 100% of our of the requirements for the triage tent. I will echo Sheila's comments about the mental health concerns, particularly in the kids, I would say about 11 and up. We haven't had, thankfully, any completed suicides, but we have a much higher transfer rate for suicidal ideation. And we send most of those kids to Flagstaff Medical Center for inpatient psych. But we do have a pediatric psychologist from the Valley that does Zoom visits at school, and she's been doing that for years. But we're also adding another provider there just to try to inherit some of that volume. One of the silver linings of this pandemic has been access to Zoom visits for mental health, because kids don't want to come in and go to the special mental health hallway. They don't want that stigma. And then parents missing work and school, for an hour-long appointment, but it's really like a 3-hour process in the Indian Health Service. But to be able to deliver that care where the kids are getting, are being seen at school will be a huge boon for them. But again, we only do that at one of the high schools. We're not doing that at the middle schools. So I welcome everyone's questions about what we've done. We were doing the resiliency coaching for our staff, but after about the first 8 months, it wasn't very well attended. I could look at re-engaging with that. I do think that our provider and our CMA, we staff our clinic with CMAs, not nurses, that we're struggling now. We thought we had pushed and gotten this thing licked, and then and now we're in our Delta surge, which is way less than our first 2 surges, but it just feels like we're tired, and we're still giving the same message and the same vaccine, and it's and we've just plateaued about who's going to take it and who's going to comply with our recommendations.
Thank you. So you've raised some questions that we're going to get to, but there's some questions that have come in while you were talking. So I'm going to try to see how I can keep up with the different questions. There was a clarification question asked by Antonio. Sara, are you seeing more impact on pediatrics right now compared to your initial surges?
there are more kids that have the sniffles, but they're not aggressively ill. We're not admitting them and we're not transferring them. We've only admitted one COVID kid to our peds ward since we opened in May, and she was 11-year-old unvaccinated. Her family was fully vaccinated. Her dad's an EMT, but she couldn't be vaccinated because of her age, and she was morbidly obese and diagnosed with type 2 diabetes, but not controlled. And she ended up needing some high flow, and we sent her to Flagstaff to just to make sure that they were treating kids better, I think, than what we were able to provide for that higher acuity. But no, we're not seeing a ton of kids admitted for any kind of respiratory stuff here. You know, and it hasn't rained that much in Tuba as it did in Flagstaff, some, but not like it was. And it's still, you know, upper 90s, and kids are still playing outside. I will say that one of the unintended side effects of having all this Zoom school, our kids didn't have devices in their homes before school went fully online, and so video games were not a huge problem for our kids in Tuba City. Kids, you know, access to YouTube and the internet wasn't something that was at the forefront of our practice. Kids don't usually get a cell phone until they're about 15 in Tuba, and even then they don't have internet data. They only have texting capabilities and some minutes. And so that's going to be a real shift for my practice, is to start counseling kids on screen time. It's not just TV anymore. It's what are you accessing with your new tablet that you got from school, and how are your parents monitoring that? And then the vast number of hours of sitting on your butt doing that has just really contributed to our obesity problem.
Yeah, thank you. Well, we have questions on topics that would take up far more than the 10 minutes we have, but we're going to touch on each of them quickly as best we can, and maybe bring some topics forward into future conversations. So first topic, school supports. Thoughts from anyone on our panel?
Well, just a couple thoughts from the chapter, the Arizona chapter of AAP. We recently were funded for a grant to increase outreach to high-risk adolescents and then also school children via a social media campaign, also posters, et cetera, and so forth. So it was in partnership with National AAP and a marketing organization to create catchy, you know, sort of outreach advertisements like, here are the needs, here's how you get it. A lot of them were vaccine-based, but also other support services. I would also note that I think a lot of our area community docs and certainly the hospitals have a media presence, whether it's through interviews or sort of chats, very similar to this panel session, that is getting the word out through public access television, news stations about resources, the needs, and including mental health concerns, which I realize and recognize is a very big part of this pandemic for kids. So I think there are resources, but it's difficult to coordinate because one size absolutely never fits all. And for Sara specifically, a lot of the social media campaign is not accessible to people who are without resources, and especially our Native and First Peoples, and including language. So the cool thing about the outreach through the Arizona AAP chapter national is putting this outreach into different languages, representing, in this case, Arizona's different peoples. We cannot capture all 22 distinct Native peoples, and not everybody has a written language, such as the DNA, but others do. So trying to reach out through tribal leadership and get access to them to help increase awareness of resources, it's a step in the right direction.
Thanks. Sheila, were you going to comment?
I was just more on a practical issue of what's happening in the schools here around us, and that's if the parents give consent, the nurses at the school can test for any of the 8 complaints that someone might have at school for COVID. And so that, I think, has cut down a lot of the school age demand and frantic nature of testing. And I don't know if that's something that can be done out where you are, Sara, but it has really, and the school nurse coordinator here in Flagstaff has worked diligently with the health department to create some educational materials and some algorithms that we've actually used and passed off to the kids and to families in our office.
Thanks. So important. From the behavioral health and the mental health topic, we all know that young people were experiencing increased burden and challenges before the pandemic. And there's some evidence that it's in some parts of the country even doubled since that time in terms of rates of anxiety and depression. I believe there's so much increased focus on this. And we recently had a grand rounds just on this topic, that I am hopeful that if we continue to work together, that we can leverage both innovations, as Dr. Jager mentioned, and the use of telehealth that someone mentioned in the chat, as well as training and just new ways of learning to roll out in types of interventions that are meaningful and effective for young people and their families, because the burden on parents is significant. That if we can keep that and decrease stigma and normalize conversations, working with our partners across cultures and across languages, that we can continue to improve and support kids as they have these needs. If we don't ask about problems and screen for them, as the AAP has taught us, then we can't find them. But supports can happen on so many tiered levels, but we all have to commit to doing that together. Mike, were you going to comment?
Oh, just goes a comment on the behavioral health. I mean, we certainly have seen a marked surge, as you mentioned, and our inpatient unit for psychiatry only takes up through age 12, and when we have sometimes 35 adolescents holding in a hospital to try and receive care, it's been a challenge. We've had to kind of redo our model of how we are managing them while they're here. We used to just kind of hope to get them transferred out soon, and they're spending a long number of days here. So we're actively, added resources in providing care to try and help them to be able to be discharged to a bridge clinic or some other place to receive care rather than waiting to be transferred to a facility. But we definitely have seen a huge surge, and it contributes to just taking away resources from other things that we need to accomplish with our sick patients, medically sick patients.
Right. Yeah. Thank you for sharing that. I do think, though, it's an example of that learning and that hopefully normalizing of that conversation, that we may not be able to address everything right away, but together, if we can commit together. And I know so many of the participants and attendees today, some people have texted me during the session, as well as entered comments in the chat, that you are working in this space, and to be able to broaden those models of support for the mental health, behavioral health needs of the entire community, but especially for our kids. That's so important. So I applaud you for that. Also, we have to continue to work together for our health professionals and supports for the caregivers, as I mentioned multiple times, and I'm sure multiple attendees today. There's no easy roadmap for that either, except for us learning, sharing, and supporting each other moving forward. There is a well-being collaborative for health professionals that is open to anyone in the state. Just you can go to wellbeingcollaborative.org to learn more about that, or please reach out to me if you're interested in learning more about that or becoming involved. Dr. Jager, I'm going to share one brief thing that you shared about 6 months ago when we were having a conversation in another type of meeting, in a coalition meeting, around small things that made a difference. And I remember you shared that your ICU staff had asked to go and be part of giving vaccinations. This was back in the spring. So they could actually be part of prevention, be part of moving upstream of illness, and how surprisingly helpful and therapeutic that was for some to be able to do that. I got so many comments about that later as such an insightful way of engaging folks in healing who have been through so much tragedy. And I think there's a lot of this learning in the state that we continue to have to identify and want to share with each other. So I wanted to give you a shout out for that.
Thanks, Mark.
There have been questions and you brought up some key things we don't have time for, Sarah, around obesity interventions, vaccines, and learning how to communicate more effectively, motivational learning, motivational interviewing, more open, receptive listening skills that we can all benefit from. I know I can benefit from these as we move forward. Those will be topics for us to discuss later. I just wanted to acknowledge them here. And the key issue of staffing. Some folks had chatted in increased use of telehealth and technology. I know many folks are doing that. Nursing students or folks in training, and I know many organizations have done this, but of course we have to be careful of not having people asked to do things before they're ready to perform and do things. And fortunately, the tremendous commitment of your organizations and others in the state has allowed for sufficient elasticity that we've just been getting ourselves through these surges and this latest surge, it seems, without having to ask people to do something they're not quite ready to do. But I do know that many folks have actually engaged young people or people that are in training programs to help. But our staffing challenges are not over moving forward. And any final comments from any of you just on that topic of staffing before we close today?
I'll just make one comment, Mark. Someone had posted a question about, using students and whether we can get authority to do it. We're in constant communication with the governor's office around these things, because not just nursing students, we could use paramedics, National Guard medics at certain times when we're so busy just to have them do some task. But we let learners back on the campus a long time ago, and having the various groups that we have here does help us because they do help provide care. So we're looking at every opportunity to get extra bodies in here to help out with moving patients through and getting care done.
Yeah, thank you for that. Okay, one last question before we close. I said the last one was the last one, but I just noted another one. Grandparents traveling to see grandchildren, especially newborns. If vaccinated, still travel? Unclear. Any final thoughts from any of you? Dr. Elliott?
Great. It make me the meanie. Thanks a lot, Mark.
I'll support you. I'll support you.
Prior to Delta variant, the answer would have been go for it. Absolutely. You're protected. Everything's fine. But unfortunately, until we can see what happens with persisting immunity from vaccine against Delta, it does appear that vaccinated individuals have the potential to still be contagious if they're exposed to or asymptomatically infected with Delta variant. So I would have to say that I would be cautious about traveling to see, especially brand new babies. We don't want those infants going to the emergency department with fevers because they're going to get work up, they're going to get exposed to hospital viruses and everything else. So let this surge reduce itself before we start making our travel plans again. And we're close. It's plateauing in other parts of the world for sure, the country as well. Give it another couple weeks and see where we stand. But for now, I would hold off.
Yeah, that's very wise. And for any of you parents or grandparents listening in that have traveled already or have plans to do so, my response is you have to find the right balance in your lives for what's meaningful for you in the situations you're in when you want to see and be with loved ones. That expression of love, our ability to connect with folks is what helps our mental and emotional well-being. We have to use our best judgment, but boy, we should forgive each other and forgive ourselves when none of us can perfectly follow the letter of the rules and protocols that we like to see in place. That is something I think is just so important, and I appreciate so many of you continuing to teach me about that. Well, with that, we will close. Thanks for everyone for joining today. Thanks especially to the panelists. Really appreciate your expertise. I'm so thankful to everyone who joined us today and our entire care delivery system around the state, including our public health team. Please continue to mask up as best you can, to care for each other, to have patience with each other, and always to spread kindness. We'll talk next time. Bye now.
Thanks, Mark.